Hello everyone, thank you for joining me today. My name is Tenzin Wangdak Yuthok, and I am a project manager at Stanford Medicine. I'm excited to be sharing the results of the Strong D study, a project focused on assessing the impact of different exercise regimens on type 2 diabetes in normal weight patients. I have no disclosures to report for this presentation. Today, we will be starting off with the landscape of type 2 diabetes and physical activity levels. From there, we will be discussing normal weight diabetes and how it pertains to the aging population. And then, we will then be discussing findings from the Strong D diabetes exercise study. The burden of type 2 diabetes has been growing across the world. Recent CDC data shows that 11% of adults are diagnosed with diabetes, with many more falling into the prediabetes and undiagnosed diabetes categories as well. By 2050, trends forecast that the prevalence of type 2 diabetes will increase to 30%, with an over 300% increase in annual healthcare costs related to diabetes. In the context of our aging population, a staggering 1 in 3 adults over the age of 65 are diagnosed with type 2 diabetes. As you can see on these curves on the right-hand side, that when comparing older versus younger adults at the same adjusted diabetes incidence rate, older adults have a higher incidence of diabetes at lower BMIs. Looking at the data for the rate of 10 cases, the BMI for younger than 50 is 30, while those above 50 is closer to 25 to 26. These trends highlight how the prevalence of diabetes is at lower BMIs disproportionately affects certain populations. Approximately 20% of individuals with type 2 diabetes have a BMI of less than 25. This category of normal weight type 2 diabetes is more commonly seen in older populations and in individuals with Asian ancestry. We have also seen an obesity paradox at play. Adults with normal weight diabetes have doubled the mortality rate of those who are overweight or obese. The reasoning behind this was theorized to be the adiposity, particularly metabolically active fat like visceral fat, or due to relative sarcopenia. And at that point, deeper research looking at the impact of exercise on body fat and composition in normal weight diabetes had not yet been done. And so the majority of global diabetes prevention trials enroll overweight or obese individuals. There is a dearth of trials and research looking at prevention in normal weight diabetes patients. Additionally, the U.S. Preventive Services Task Force emphasizes high BMI as a main screening criteria for type 2 diabetes screening. This overlooked a substantial number of individuals at normal BMIs, especially from race and ethnic minority groups. Overall, data on the most appropriate treatment for normal weight diabetes is scarce, and stronger evidence is needed to inform adequate prevention and treatment recommendations. Current recommendations suggest exercise, especially aerobic exercise, as an effective and accessible method of managing type 2 diabetes. Regular exercise is a key factor for preventing cardiometabolic disease and the management of type 2 diabetes. The physical activity guidelines for Americans state that adults should be engaging in 150 minutes of moderate, or 75 minutes of vigorous physical activity a week. However, only 1 in 4 adults is actually meeting those recommended amounts. So how can we optimize exercise regimens to effectively improve type 2 diabetes outcomes for our world's aging population? The purpose of our study is to get us closer to answering that question. The STRONG-D trial examines the effects of strength, aerobic, and combination training on glycemic control in people at normal weight with type 2 diabetes. And here's an overview of the trial study design. Patients are randomized into one of 3 arms. In these arms, patients engage in exercise regimens focused on strength training alone, aerobic exercise alone, or a combination of the two. The active intervention period is 9 months long, and hemoglobin A1C tests are administered at the baseline, as well as the 6, 3, 6, and 9-month visits. And these are some sample regimens that we have for each arm. Participants engage in exercise for a minimum of 3 times a week, each session being about 60 minutes long. These exercise sessions took place in an exercise facility, such as local gyms. For the aerobic training aspect, patients were asked to achieve a training intensity between 50 to 80% VO2 max. And here is a consort diagram of the trial. 168 adults with a median age of 59 were included in this analysis. 40% of participants were female and 83 were Asian. One thing to note is that COVID shelter-in-place restrictions were active during this part of the trial, and so that had an impact on patient engagement levels and follow-up. The average BMI for STRONG-D participants was 23.7. The primary outcome of our study was change in hemoglobin A1C measurements. We found that strength training alone exercise regimens were found to be the most effective and significantly reduced hemoglobin A1C levels from baseline to the 9-month mark by 0.44%. One potential explanation for this is that 80% of insulin-mediated glucose uptake is mediated by the GLUT4 receptors. These receptors are located in the muscle, so emphasizing the building of muscle through strength training can effectively decrease hemoglobin A1C levels in normal weight type 2 diabetes patients, as they are typically at risk for age-related muscle loss. Previous studies in overweight, obese individuals demonstrated that structured exercise is effective in improving glycemic control. Both the previous DARE study and Heart-D study reported that combination training had a larger reduction in hemoglobin A1C, followed by aerobic, and then finally strength training. The average BMIs for those 2 previous studies were over 33 each, and no previous clinical trials were conducted on those with normal weight type 2 diabetes, and which again is more common in Asian populations as well as older individuals, and it's likely to be related due to relative sarcopenia and placement of fat depots. And the graphs here on this slide are contrasting the results that we see from STRONG-D and Heart-D. The main difference you can see is the BMI, as well as comparing the individuals in the strength group of Heart-D and the strength group of STRONG-D. STRONG-D achieved a higher absolute mean reduction in hemoglobin A1C levels, despite less diabetes medication intensification compared to the strength training group in Heart-D. And then on this slide, you can see Other process measures seen in Strong D. So our biodex data is on the left-hand side and DEXA is on the right. The biodex measured muscle strength and DEXA scans looked at bone density and body composition. With regards to overall body composition, appendicular lean mass significantly increased only in the strength training group alone. Overall, we found that strength training exercise regimens were found to be more effective in lowering hemoglobin A1C levels in patients with normal weight type 2 diabetes compared to aerobic exercise alone or combination regimens. Strength training better improved both lean mass and total work in muscles compared to the other arms as well. These findings are significant, as various exercise regimens have been shown to impact hemoglobin A1C levels in diabetes patients with lower BMIs differently than those with higher BMIs. Limitations of this study include limited follow-up data at the 9-month mark and complications due to the COVID-19 pandemic. Further work in understanding the mechanisms underlying diabetes management and treatment in patients with normal weight type 2 diabetes would be a meaningful next step in understanding how to optimize exercise regimens to effectively improve these outcomes. A big thank you to Dr. Lakapalyapan and the Strong D team at the Stanford Discover Lab, and thank you to the organizers for allowing me the opportunity to present this work today. Again, I appreciate your time today, and thank you everyone.